Hello, my name is Michael Connolly, Joint Associate Professor of Clinical Nursing at UCD School of Nursing, Midwifery and Health Systems and Our Lady's Hospice and Care Services. The World Health Organization designated the year 2020 to be the International Year of the Nurse and Midwife, a celebration of nursing and midwifery and the contribution of nurses and midwives to healthcare and the provision of healthcare and education across the entire globe. When that designation occurred, no one expected or anticipated where we were going to be in 2020 in the context of health. My colleagues in nursing and midwifery have been on the front line, in hospitals, in residential care centres, in hospices, and in the community, where the vast majority of our care happens. As a testament to the work of nurses working in community palliative care, we're going to hear from some of our nursing colleagues who work in that space. They're going to share with us their experience of providing that community palliative care to patients and families in a time of a global pandemic. I want to acknowledge the contribution that nurses and midwives make to our healthcare services, and in particular those nurses who work in palliative care. While 2020 has been designated as the International Year of the Nurse and Midwife, I'm delighted that the World Health Organization has decided to extend the International Year of the Nurse and Midwife into 2021. Again, testament to the value that the World Health Organization places on nurses and midwives and their contribution to the healthcare system, because without nurses and midwives, there isn't a healthcare system. I now hand you over to my colleagues who work in community palliative care team to hear of their experiences. Thank you.
Hello, as Anya mentioned, I'm Nora McCarrick, nurse manager of the community palliative care team in St. Francis Hospice in Blanchardstown. COVID-19 has proven challenging for everyone globally, and St. Francis Hospice has been no different. Despite the pandemic, we have continued to provide our gold standard care. At times of great isolation, our team has managed to maintain contact and support. An elderly lady was referred to our service and was being cared for by her elderly husband. However, when we attempted to visit, he declined our involvement. We gently explored his reluctance to discover he had great fears around himself contracting COVID, and so feared that he would become unwell and be unable to care for his wife. We reassured him, and he did allow us to visit, and we have now developed a relationship with him and his wife, and they look forward to our visits to their home, taking full COVID-19 precautions at all times. COVID has changed society greatly, but we will continue to deliver our holistic, patient-centred care despite these challenges as we move into the future times.
Hello, my name is Ruth Hutchison and I'm a Macmillan Specialist Palliative Care Nurse within the Community Palliative Care team in the Southern Trust. I have worked in Specialist Palliative Care for almost 25 years. 16 of these were within a hospital setting, and lately the last 9 years have been in the community. Throughout my time within palliative care, I always felt it was a privileged position to be in to help care for patients and their families during this difficult time in their lives. To help reflect this, I thought it would be best to use the words of my patients' families. These are a selection of cards I have received with patients' names removed for confidentiality. Words are not enough to express our sincere gratitude for your support throughout my husband's final weeks. I am forever thankful that with your guidance, I was able to keep my beloved husband at home, where he wanted to be, with his family by his side. Just a few words to thank you for your help and guidance through the last part of our dear son's journey of life. You have been compassionate and understanding in all your dealings with us, and we will never forget you. Our warmest regards. Thank you for taking the time to listen to me portray thoughts and comments of my patients' family and friends who have experienced palliative care.
Hello, my name is Zara. I'm a district nurse within the South Eastern Trust. and I work with palliative and end-of-life patients. The district nurse is identified as the key worker within the community team, very often making referrals to other allied health professionals within the palliative care team, including the OT and physio. We work alongside and very closely together with the GP and with the community hospice nurse delivering palliative care and end-of-life care. Some of the key challenges, the most recent one really, is working within the restrictions of COVID-19. We recently had a young person who was in hospital, receiving a terminally ill diagnosis, who came home, had been very isolated within hospital because relatives weren't able to visit. And once the person was able to come home, they were surrounded by their family and supported through their terminal illness. Another challenge we would have is time frame. Our palliative and end-of-life patients are prioritised in the care that we deliver, but we also have a range of other patients to see, and we have to prioritise their needs along with palliative care patients to ensure that there's equity in the delivery of care. The most rewarding part of my role is caring for patients in the community with palliative and end-of-life needs. To be able to support someone to stay at home through their illness right up to their time of death is very rewarding, because they are placed where they want to be. They're with family and they're with friends. And the family provide a lot of support usually in these times, and they're very appreciative of our support to facilitate their loved one to stay at home. It often means anticipating needs, and then to prevent such things as pressure damage, to identify any lack of symptom control. Do patients need help with independence? Do they need referrals to any of the other allied health professionals, such as a physio or OT, to maintain their independence, to have aids supplied? Very often too, after the patient has passed, the relatives, as part of their bereavement, it is a comfort to them to know that they have helped their loved one to be nursed at home. One of the patients in our care, her son said after her death, it takes a village to raise a child, and it's the same within palliative care within the community. It takes many people to enable someone to die comfortably at home. And this is a part of the job which is very rewarding, because you're working collaboratively with the patient, with the family, with GP, hospice nurse, and other allied health professionals. There's good communication between the teams to provide optimum care within the community.
My name is Anya Hughes, and along with my colleague Nora McCarrick, we manage the community nursing palliative care services in North Dublin, based in St Francis Hospice. As a team, we support people who are living with a life-limiting condition and their families in their homes, wherever that may be. Our aim is to help patients to be as well as possible for as long as possible, and to live their full potential in their home if that is their wish, to die at home with their family around them. Our team consists of doctors, nurses, chaplains, social workers, physiotherapists, occupational therapists, and we're supported by administration staff and volunteers. We use our specialist palliative care knowledge and experience to work alongside the patient's general practitioner and their public health nurse. Although part of a wider team, our experience is that the clinical nurse specialist plays a central role in caring for the person at home. We generally are a constant presence, and we act as a liaison between the other professionals involved with the patient. It can be very frightening for the patient. It is possibly their first contact with palliative care and what palliative care means. So for every person, it is an individual experience. Some people are actually very relieved that we're involved in their care, because they have felt alone and isolated on a journey that is very difficult. For other people, the mere mention of palliative care brings fear. And in fact, in some cases, that fear has prevented referrals to our service. We do our best, obviously, to allay all the fears that these people have. So our first job when we go into someone's home is to try and do that, to explore the fears. The fears can be many. Many still remember that a hospice was only a hospice for the dying, and hospice has evolved over the years and has changed. We see many, many people at different stages of their disease trajectory. For some people, we see them for a brief period of time to help with symptom management, and for others, we see them at the end of life and we are more involved. The first meeting is so important. We remember that we're guests in the person's house, and they need to get to know and trust us. The first meeting is the first step on a journey that both the nurse and the patient and the family travel together. This journey can be short or it can be long, but the importance is that we have a relationship that is a trusting relationship, and it is about getting to know the patient and the family. We often become involved with patients who in somehow have resonate a feeling inside of us, or perhaps a reflection of a family member that we have lost, and that can be very difficult. Many people ask us, oh, working in the community, working with patients must be very sad. And yes, it is very sad. We are very well supported by the hospice, by our other professionals that we work with. And this is a very important part of our work. I suppose as a nurse, it is a great privilege to be a part of the person's journey. And as I said, it also can have an impact on us personally. The most rewarding part of our work is the support that we offer to the patients and families, the symptom management, and imparting our knowledge to the patient and family, which allows them to stay at home for as long as possible or until they die. The journey of the patient is travelled by many. It's travelled by the patient and their immediate family and their friends, and by the health professionals involved with their care. As I said, we are involved with patients and families for different lengths of time. And I suppose the most rewarding part of our work is that support that we offer along that journey as we help the patient and their family adapt with the many and significant changes in their lives.
Hello, my name is Bridget Lyons, and I work as a community palliative care nurse in the Galway Hospice. As a nurse working on the community, establishing a good connection and rapport with both the patient and family is essential in order to develop a good therapeutic relationship. The patient may be at various stages of treatment, and so it is vital that they have time to explore their own fears and anxieties around living with a life-threatening illness. Equally important is establishing a good relationship with families who will be experiencing their own personal emotions at this time. Sometimes communication may be a little bit fractured between the patient and family, until time is spent dealing with concerns and issues professionally and sensitively. Often when we meet patients and families for the first time, there is uncertainty around our role and how we fit in with the provision of care, sometimes confusing us with the public health nurse and the home help. They may be anxious around the term palliative or hospice, and so again it is important to be able to define our role and how we are part of the multidisciplinary team working in the community. With each visit, there are opportunities to discuss their preferred place of care, establishing their ceiling of care, along with essential pain and control symptoms and psychosocial support. Joint working with the PHN, particularly as a patient approaches end of life, works well and is a great source of comfort to the patient and family at this time. Sadly, due to the current pandemic, we have needed to adjust to a different way of working in the community. A more verbal assessment, along with a COVID screen, is carried out over the telephone prior to our visit in order to minimise risk. The importance of social distancing during the visit is essential. The welcome handshake and the usual cup of berries has now given way to gloves, apron and a mask, making the job a little more clinical than personal. As a community nurse, going into a patient's home, I feel privileged to be part of a bigger team who are able to provide support to patients and families when they are at their most vulnerable. To have the opportunity to remain at home of end-of-life care is so important and one greatly appreciated by all involved. Finally, having worked in palliative care for many years, I feel my experience of caring for patients and families in many different settings has been the most rewarding chapter in my nursing career to date. Thank you.
My name is Fiona Flynn and I am the Hospice Hub Multidisciplinary Outpatient Manager here within the Care Directorate at Northern Ireland Hospice. It's a hybrid post with both a clinical aspect in relation to the delivery of rapid response, the triage referrals, and an operational management aspect and everything that comes with that. It allowed me to understand where some of my colleagues were coming from, and I was able to support them through their challenges as well. I suppose the paradox of COVID has been, on one side, it has been challenging, it has been difficult, it has been extreme. There has been a lot of distress for families and for colleagues that we work with on a day-to-day basis. And on the other hand, it has been the catalyst for change and has brought out the best. One patient assessed by rapid response was a 42-year-old gentleman with 3 children, the youngest being 5. He presented to one of the local ED departments with a short month history of right upper quadrant pain. He and his family were doing the normal things that we all do, year in, year out. They were planning their summer holiday and had actually booked flights abroad. He presented to ED. He said to his wife, "You go on the holiday. I'll get a flight out tonight or tomorrow night and I'll see you then." He was subsequently admitted to hospital and diagnosed with metastatic pancreatic disease with bone mets. He had surgical opinion while in hospital, but unfortunately was informed that there was no intervention from a surgical perspective. He was discharged home a week later, the same day his family came home from holidays. So the triage detail was very clear. This was a 42-year-old man, newly diagnosed at home with severe pain, anxiety, and a very distressed family, and appropriately distressed. So rapid response assessed him at home that day. He had severe abdominal pain. He was constipated. He had terrible thrush. His bowels hadn't opened for 7 days. His fluid intake was low. And he was very anxious, very distressed, as were his family and his children. Good. Undoubtedly, it was a very challenging rapid response visit. This was a gentleman with a lot of complex symptoms, but there was one thing that both he and his family were very clear about. Although he was still waiting on an oncology opinion, he wanted to be at home, and his preferred place of care and his preferred place of death was home. He was admitted to the inpatient unit the next day. He underwent another opioid switch. He had other adjuvants like ketamine and steroids introduced, benzodiazepines and mirtazapine, Creon, again another laxative regime. He had an acidic tap. He had IV antibiotics for spontaneous bacterial peritonitis, and holistic NDT support, not just for him, but for the members of his family that were with him at hospice, and social work support for his distressed children. Obviously, during admission, there was intense multidisciplinary support for him and his family. In terms of advanced care planning, his preferred place of care from rapid response to his admission to the IPU didn't change. He still wanted to be at home. He was reluctant to discuss his prognosis. He was frightened. He was very frightened, and he prayed that God would take him. He was frightened to die. There were discussions around the dying process, and conversations were facilitated both for him and for his family from the multidisciplinary team. He was discharged home 2 weeks later, after multiple interventions and MDT support, at his request and at the family's request, as he continued to deteriorate, we held his bed in the inpatient unit to ensure that if he went home, if things were going well, great, but if it wasn't working out, that he could come back into the unit. A rapid response visit was carried out the day after discharge. It was clear that this gentleman was actively dying, but he was comfortable. He was glad to be home, and his family were so delighted to have him at home and to be there with him. He required a couple of stat doses while we were there in the house with him, and we left. Medical domiciliary visit was provided the next day after rapid response, and again, he was very glad to be home. His family were glad to have him home, but he was actively dying. He'd had a difficult night overnight. His wife became concerned about blood-stained acidic fluid in his bag, and they contacted Out of Hours Support, who offered attendance at ED, but they declined that. We titrated his syringe driver that day and obviously offered support to him, to his wife, to the children and the rest of the family. He passed away the day after his medical domiciliary visit at home with his family. And obviously they've been offered bereavement follow-up from our social work team here at Northern Ireland Hospice. And I suppose from my perspective, it's the impact that we have. It's what we can do to help people on their journey to live while dying. And that's what I've learned here in hospice. They're the skills that I have learned working with the multidisciplinary team. That's why I love my role. That's why I love working here, because this is the impact that we can have on people. This is how we can improve their quality of life.
I began my career in nursing 30 years ago next year. One of my earliest posts was in a unit for patients with HIV and AIDS. As a very young, newly qualified staff nurse, my experiences there had such an impact on me that I realised very early on that palliative and end-of-life care was the speciality where I wanted to work. I spent a number of years working in inpatient and community settings in palliative care in England and returned home to the beautiful Northwest around 10 years ago, where I've worked at the Foyle Hospice ever since. As nurses, we're constantly challenged to update our knowledge and skills, to read, to critique, to apply, to analyse and to evaluate. There are a number of definitions of what palliative care actually is at global, international, national and local level. We have national and local strategies to work to, objectives and standards to achieve. But at a very fundamental level, when faced with human suffering and need, these are some of the questions that I know that the patients I have cared for and will continue to care for are concerned about. And that it's by helping to find the answers to these questions that I meet the objectives of the role that I have as a specialist community nurse. My body's changing so fast, weight loss and disfigurement from surgery and these treatments. I have so many physical symptoms and I'm in pain and feel sick so much of the time. I can't do the things that I could do a month ago. I can't drive or play badminton or cut the grass. Is this all just going to get worse? These medications are overwhelming, so many of them. I don't know what I'm taking for what. They can't be good for me. The fatigue's overwhelming as well. There must be something that you can do. I'm so run down. I used to be able to fight off a cold. Now I catch every infection going. I feel so ill a lot of the time and I'm constantly on antibiotics. I'm living with so much anxiety, so much uncertainty and unpredictability. How do I deal with all this emotion and all these mood changes? The drugs are making my head fuzzy. I can't think clearly. I have so much to take in about treatments and medications. Why can't I remember what the oncologist said? We were planning a holiday for next year. Even that's in doubt now. So much uncertainty. I used to be so independent. Now my wife has to help me shower. I can't even look after myself properly anymore. I'm dealing with so many new people in my home. I've never needed district nurses or carers. I don't even know what everybody does. What is it you do again? What do I need to do next? I really want to stay in my own home. Is that possible? I have to stay strong for the children. They're not coping well. I don't see anybody anymore. I miss Bingo so much. But why me? This is not fair. I've always avoided thinking about death and dying and mortality. Now it seems to be slapping me in the face every day. I don't care about the car or the caravan anymore. They're just things. I just want to live. I've lost everything. My job, my independence. What's the point in all of this? I really want to talk about the future. I want to make plans, but my husband won't let me and the children just get upset. Very often patients and families can be totally overwhelmed when they hear that they've been referred to specialist palliative care services. But our feedback has consistently shown that the care that we provide makes a significant improvement to the quality of life for our patients and their families. By using advanced communication skills to listen, to respond, to support, and to help plan, we encourage patients to take control of their journey, to empower themselves and their carers, to manage medications and symptoms, to record and communicate about their wishes, to make choices about their journey, how they want to live, where they wish to be for the end of life, and how they wish to be cared for, and most importantly, to achieve the things that they want to achieve. It has its challenges. It brings tears of joy and sometimes sadness. But in every aspect of the care that I and my colleagues deliver, be that physical, psychological, social or spiritual, we are honoured to be able to impact positively the care of our patients, enabling them to live well.
Hi, my name's Lisa and I work as a community lead in Laura Lynn. I just said I'd give you an insight into my role and also how I came about working in the community. I worked in a paediatric ICU and I suppose they focused a lot on quantity rather than quality of life. And palliative care team were most often seen as a last resort. But while I was there, I did do a course in palliative care and I met a lot of great nurses who worked in palliative care in the community or in hospices, and I just loved the sound of their work. So I applied then for a position in Laura Lynn, and I was a staff nurse on the community team. And I suppose I never appreciated when you send that family home and that child home after a surgical intervention in hospital, you don't realise that this can sometimes be the start of their road or their journey. And you get a huge insight when you go behind that door and their day-to-day lives. And I've developed a really big understanding of what's important. And what's important to one family may differ to the next family, or their wishes and preferences may change over time depending on the child's disease trajectory or what they've been through. So it's really important as a community nurse to treat every family as individuals and also adapt to changes according to their wishes and their preferences. And I suppose at Laura Lynn, we really do try to do this as best we can and advocate that it is all about quality of life and making the most of each day for that child and that family. And I know it's been very tough through COVID, especially in the community. We've had to adapt to a lot of differences. And it is hard to provide direct care as much as we did before. But I've one example that even though it's small, it does make a difference to this child's life. And this child has a brain tumour and is in the community. And we do a weekly call with her and her mom. And she used to love coming up to Laura Lynn. So she knows everyone from people in the fundraising department, the cleaners, and the receptionists in Laura Lynn, nurses, HCAs. And she loves to be put through to everyone. And she asks the receptionist if she's all up to date with her emails. She'll ask about the keys to the storeroom and is everything put in its place. And she'll say that is her bed ready for her when she comes up again. And to us, I suppose it's not a big thing, but to her and her family, her mom will always say that that's what she looks forward to every week, is that weekly call to Laura Lynn. So I suppose it is challenging, but all we can do is do everything we can for these children and their families and try and make a difference. So thanks for listening.